can see when they've gotten what. But that's of course, put up boundaries. That's what you have to do. The ER, I'm so sorry, I guess is what I'll say. It's a hard spot to be in. But I think that the other thing is there are, most recently in our pain clinics, they've been using ketamine, which is a really good option, and I think that is something that hopefully will help. And then lastly, I think one support or one way to help address this is oncologists and primary care doctors and other providers that actually that are in the position where they would write narcotic prescriptions also are very busy. So it's hard to educate. It's hard to our clinic that does palliative care. We have our pharmacist. We have a dedicated pharmacist, and he goes in and he teaches, and they go through an opioid education session, and then if it's the right scenario, you sign the opioid contract, and then they have continued education with a goal to taper off. And if that happens from the beginning, then the success rate, I think, will be better. I think in the past, we, as a society, I don't think it was not malintentious, but we started at pain as a vital sign, right? And that's what I think triggered this whole, we have to treat pain adequately, and just like with other drugs or any other addictive substance, tobacco, I know you and I have had discussions about tobacco, and it's been mentioned earlier that this weekend, those kind of things have it's just like it's an epidemic, and people have the funds and the ability to get it, and I think that's what's led to where we are now. I just hope that we can negotiate a good taper off as a society off of that, because there are significant, as you well described, patients that actually need it, and it's their life-saving treatment, and it's going to be a hard balance, but hopefully we can all tackle it together.
I was just going to comment too, and I think you guys would completely agree, everybody. When we look at pain management guidelines, there isn't anything that says that narcotics should necessarily be first line or only line, as well as when you look at those pain management guidelines, massage therapy, acupuncture, mental health, exercise, all those things, and in survivorship, well, in primary care as well, but in survivorship, I have a lot of people with chronic pain issues, and when I ask them if anybody is even recommended, and I'm just going to go on their word, acupuncture or something like that, oh no, or they say it's not covered under my insurance, and many places, larger communities have community acupuncture clinics that do a sliding scale, sometimes to $0 or $10 a visit for acupuncture, because Medicare has never covered acupuncture, and so there's ways to get around it. And we'd never say to somebody with raging high cholesterol, oh, well, let me just give you enough Lipitor, that you have no cholesterol left. We'd be talking to them about their smoking and their diet and their exercise, and we just have to we have to be making that more acceptable and more accessible for people too. Not that the narcotics don't do their job, but they have their place.
Excellent point. Thank you.
In case you didn't notice.
You can actually buy it on Amazon.
Yeah, right. I've had patients that have purchased it, and I just, me personally, however we can get people's pain under control in the safest way, I think is important.
I would say I hear from patient report. I'm not a big one just having people with the THC, which is the component in the cannabinoids that make you stoned, okay? But we actually have cannabinoid receptors in our systems that are there. I mean, probably because because there were hemp plants way before we had morphine derivatives, and so people have been in pain like since there were people, right? And so I think that if there's education and knowledge, and if we try to really reach out and get that information, there's so little out there because it's still illegal on the national level that there aren't good studies and everything. So hopefully there's more studies. I do talk to people a lot about CBD because I feel like they can use that topically. We know it doesn't come through their urine and show up in their drug test at work, but if they can get localized symptomatic relief with that, and they're not driving while stoned, then that's good for me. I have to say I don't recommend the THC, but I do talk to people a lot about edibles or tinctures or topicals with the CBD, and it seems to help.
Yeah, sure, thank you.
I don't want him smoking.
Well,
Go to Bellingham and you'll find out.
with most of the clinics that I've worked with, and the primary cares that I've been in, the doctors have signs. If you are going to need a refill, let us know, because give us 48 hours. And with the patients that we have in oncology that are in pain, when we see them on our weekly visits, make sure that they have enough narcotics through the weekend so that they're not calling anybody on call for a narcotic. So I think that has helped in the physicians trying to be proactive with that. That's my point.
That is an excellent point.
Yes.
So something that we need to learn and possibly implement in our places. Yeah, thank you. All right, so it was an excellent session. A lot of enthusiasm, a lot of participation. We'll come back at 2:30.